All right. Well, good afternoon, everyone, and thank you for joining today's session. My name is Casey, and on behalf of the PRRP Exchange team, we are excited to have you all here. Today, you will have the opportunity to hear updates from your peers on their state or territory's emergency department or pre-hospital recognition program. So we are excited to learn from those with well-established programs and from those who are just getting started. Before we launch into today's session, we would like to acknowledge that the EMSC Innovation Improvement Center is funded through a cooperative agreement with the Health Resources and Services Administration, which is within the U.S. Department of Health and Human Services. As a cooperative agreement with a federal agency, the EIC must adhere to executive orders and related federal guidance. Currently, EIC-funded staff are unable to engage in activities or discussions on topics that are limited by executive orders. We appreciate your understanding and ask that all meeting attendees refrain from discussing any topics of concern. Additionally, contents of today's presentation are those of the authors and do not necessarily represent the official views nor an endorsement by HRSA, HHS, or the U.S. government. A few housekeeping items before we hand things over to you all. Today's session is being recorded and will be posted to the EMSC website along with today's presentation on the PRRP Exchange pages. As always, we look forward to having an interactive session with you all, and we ask that you turn on your cameras, ask questions of one another by raising your hand or coming off mute, and we look forward to your contributions. So today, we do look forward to hearing updates from a number of our participants. So please use this as an opportunity to learn from one another, exchange ideas with your peers. So I'm going to go ahead and get us started. I'm going to hand things over and we'll get started with an update from Emily and DC. And for all of those who are presenting today, if you would like me to share your slides, I can, or I can hand over the screen to you. So just let me know.
If you're ready to share them, that would be fine with me. Thank you. Hi, everybody. Thanks for letting me give you a quick update today on the great stuff we have going on in the District of Columbia. You can go to the next slide. We have the Always Ready for Children, which is, you've heard about it before. It's a collaborative recognition program across several states and the district. So in DC, our Always Ready for Children, we launched it in October of 2024. We have 3 levels: Pediatric, Engaged, Ready, and Innovator. We have the luxury of being able to do in-person site visits due to the size of our city district and the number of hospitals we have. The application process is currently on paper, but we do have it in our plans to move it to an electronic platform. We just haven't started that process yet. And we also do not have a website yet. So what we have been relying on so far is we've been putting together our materials, really trying to put together a professional package so that it is something that people pay attention to, they take it seriously. We are leveraging our partnership with DC Health to really get this off the ground in DC. So we've been focusing on all of these materials, really putting this nice program together and launching our pilot phase. The recognition currently is valid for 2 years. So the next slide. This is not expecting you to read the small print, but this is one of the appendices of our program manual, which is how we show any applicant sites be transparent about what their site visit is going to entail. So their application has their most recent gap report attached, so we can have that information before we go into the process. We review that with our team. But then we also have specific questions that we like to make sure that we visualize or we discuss on site with the leadership of the emergency department. So those are just specific things that, even though they may have checked a box on their NPRP assessment, that we want to talk to them about these programs, talk to them about their quality indicators, get some more information, and especially if they're going for the innovator status, really want to hear their stories about what they're proud of and what they think they can offer the region in order to help their other nearby emergency departments become more pediatric ready as well. So next slide, please. So these are some examples of what we've been doing for marketing and engagement. So since we don't have a website yet, we are relying a lot on emails, attending regional meetings, getting in front of all of the trauma program managers and directors, for example, to talk to them about the ACS requirements and how we can help them, how we can help look at action plans or help steer them in the right direction if they don't really know where to start, if they want to meet those requirements, but then we also say this is something that we should be doing on an ongoing basis and we would love to help you. So we use local preparedness conferences as well. There was also a kind of public health summit that we reached a lot of hospitals and other critical partners as well. We also use our simulation program to try and provide education and bring resources to emergency departments to look at where they are related to the care of pediatric patients in a simulated environment and help them identify some things that they do really well and some things that could be their targets for improvement. And then we try and bridge that into the conversation to the recognition program and really sometimes helping them realize that they are more ready than they think. They think we don't take care of kids, but in fact, they do, and they can do a really good job with the resources that they have. Next slide, please. So challenges, getting the word out, and multiple times, because even if they hear about it once, they need to know that we are here to stay. This is something that is endorsed with our partnership with DC Health and that it really is for everybody. So engaging those non-pediatric hospitals, that this is actually not, we were not targeting the specialty hospitals. We really wanted to target all hospitals and to help make kind of separate this program from our pediatric freestanding facility and make it something that is very accessible and within reach and something that really applies to everyone. But in the process, because Caleb Ward is on, who is our project director, and myself, we are both have been employed by the pediatric specialty hospital for many years. And so having them be a candidate for pediatric readiness introduced in committee, we started talking about the idea of bias or even the perception of bias. So I will give a huge shout out to my colleague, Mark Minkler from Maine, because what we do really well, I think, among the state partnership programs is that when we have questions or when we have like, hey, what would you do about this? We have so many amazing and experienced colleagues that we can reach out to and get their opinion and try and make things as robust as possible. So Mark was able to not only give us advice, but also be an outside independent reviewer for our pediatric hospital. And so that was really successful and really, really helpful. So I want to publicly thank him for his assistance in that process. If you can go to the next slide, please. Which leads us to, oh, I guess maybe you had to click. I didn't know I had animation in here, but there's one thing missing, which, can you click one more time to see if that's, oh, go back. So what you're missing in your slide on the left-hand side was it says, I'll bring it up on mine, that our first facility was recognized August 18th. So that was 3 days ago. Our very first facility was recognized at the innovator level. So what you're seeing on your screen is that in the middle, we have the decals that are window decals that we give them 4 stickers that go on there. They're designed to go on their entrances and their ambulance entrance facing outwards to recognize the level and the years because we would like them to apply in 2027. And I think that was Sam's idea, is that if you put the date on the sticker, then they'll be like, oh, that sticker's out of date. We need to apply again. And then on the right hand side is one of our huge, taller than me banners that we are going to house in their lobby, their main atrium and entrance for everybody to see. So we are still planning a kind of press release announcement or celebration with them, and going to design and order them a plaque as well. Thank you for all the congratulations in the chat. We're really, really excited. They at one time said that this could never happen in DC because, politics is kind of what we do, but we didn't, we kept pushing through, didn't take no for an answer. So we're really, really proud of what we've been able to do. Next slide, please, Casey. So the next steps, we're collaborating with the with all of the ARC programs to because we started working on this before the collaborative was complete and before we had the new performance measures implementation manual. So we are now kind of looking at those side by side, figuring out how we can update and revise the ARC program in a way that all of the partner states are going to be able to implement as well. So we're working on that, especially in anticipation of the new assessment coming out in the spring, the website and the electronic application, like I said. And we really want to recruit because we tried not to have our pilot site be the Pediatric Specialty Center, but they were definitely the most enthusiastic and engaged and excited to start the process. So we're working with a few other facilities who do a really good job, and we want them to be next. And how long will the banner stay? So right now it's not theirs to keep. This is our first one. So I think that we talked to other states where they get to like keep it for 3 months or so. They're not that expensive, so we could talk about that if we were going to give it to them. It doesn't have their hospital name on it. If we were going to order one individually for them, they might want that. But the plan was just for a few months. And if we don't get it back, we don't get it back. Any other questions? I know our program's going to look very different than states that have hundreds of hospitals, but this is what works for us, so we're excited. Oh, and Mark says 30 days. All right, that's it for me. Thank you.
Thank you so much, Emily. Appreciate you sharing an update today and some great examples of coordination and collaboration with your other neighboring states. So happy to see that. Right. Before I do hand things over to Tennessee, last call, any questions for Emily or about that program in DC and how things work? I will go ahead and hand things over to Tennessee.
All right, hi, it's Tasha. If you go ahead and go to the next slide. Ours is focused on our EMS recognition program. So last year I met with our EMS state director and threw the idea to him of what we wanted to do, got his approval to move forward. And then our advisory committee, we call it COPEC, the Committee on Pediatric Emergency Care. And so we have 3 subcommittees. And so I presented it to the EMS subcommittee. This is what I wanted done, and just kind of let them take the reins on it. They developed our criteria outline, and then they took that kind of like on a roadhouse across the state. So we shared with all our different EMS directors associations. We shared it at our PEC meeting, and then we also presented it to the state EMS board to get their approval on all of the different criteria and get any of their feedback on it so we can make it as concise as we possibly could. And so at our last meeting that we just had last week, they created the review and approval process. And so that is now going to look like the EMS subcommittee is going to be the ones who will review them and approve all of the applications that come through. Go ahead, next slide. And so they're going to be doing that. Oh, okay. So they're going to be doing that through REDCap. So all applications will come through there. So the recognition program enablers, this is just a list of everyone that we worked with specifically for feedback and help create it. So you can go next slide. All right, some of the barriers that we had. So when I met with the state EMS director, he was very specific. He wanted this to be a voluntary program. Our hospital one is a required program. And so every single hospital in the state of Tennessee is required by state legislation to pick one. And I was kind of hoping to get that for the EMS side as well. So maybe after we get this going and we get majority of the EMS agencies involved in the next couple of years, maybe we can relook at that. Our EMS office decided this last EMS meeting when we provided them with an update that they no longer want to be the person to go over and do the applications. Our EMS consultants were going to be the ones to review it, and they said no, they don't want to do that anymore. So our EMS subcommittee pivoted, and they are now going to be the ones to collect all of those applications, verify all the information in it, and then give the approval for which level that they meet at. So it's going to be 4 different tiers for the EMS recognition levels. And then when it comes time for annual renewal, then they'll just go through and do that same process where they upload their documents and verify that they want to either stay at the same level or if they wanted to move up or down. When I created this slide, the EMS board meeting, one of our other barriers was going to be that their next meeting wasn't going to be until December, but that has changed. They are meeting in September now. So that will help us to meet our January 1st deadline that we had self-imposed on wanting to get this open to the EMS agencies to apply. So that is no longer a barrier. We should be meeting with them next month. Next slide. All right, so our next steps. These are the logos that the committee came up with. We are going to be updating that bronze logo because it is difficult to read. We also need to get approval from our EMS board for having the details on the ambulances. They can have them anywhere on the inside based on the EMS state director, but then we've been getting conflicted information on the outside. Some say we can approve it for on the window. Some are saying you can actually get decals to go on the side of the ambulance. So waiting for approval on that from the EMS board at the September meeting to make sure what is truly allowed and what's not, because we're getting conflicted information from the various EMS consultants on who you speak with. And then our next challenge will be getting funding to be able to order all of these decals as they get certified, and getting these recognition packets. So we want to try to get like a window clings. We're going to help them write up press releases, and then having the PDF logo that they can use online for their website as well as their social media. So working on creating that marketing program over the next couple of months to meet our January 1st go live date. I believe that's it. I think that's our last slide. So are there any questions on what we're doing for the EMS agencies? Thank you.
Thank you. I have a question for you. So your go live date, will that be the start of a pilot program, or have you already got an agency that you've gone through with a pilot, or why?
That's just when we're going to open it up for any of the EMS agencies to apply to it. So we've been talking to them about it for this whole last year, so they're already all well aware of what's going on and what we're planning to do. So that's the date that we're opening up the REDCap applications. So our state has what we're called their CRPC coordinators. So they work at our comprehensive regional pediatric center, so the top tier children's hospitals. In order to be credentialed at that level, they have to have an educator that goes out and they work out in the community hospitals as well as EMS agencies. So they're going to any EMS agency that is interested in applying for this, then they are going to work with them and get the packet together and help them. So that way, when it opens up on January 1st, they can go ahead and apply. And then the first meeting that they're going to be meeting together is scheduled for February. Is there where they'll be able to actually go through and review and start actually approving applications. And so that's why they set the January 1st. So it'll be that 30-day window.
Thank you. Sounds like you have some great support systems that are helping the project. So it's great.
Thank you.
Any other questions? Question from Kelly in the chat. Can you clarify, is this an application with review only, or will there be a site visit?
So the initial portion is just a review only of everything that they upload and stuff. And then when the EMS consultants go out and do their licensing renewals, that's when they'll be doing actual site visit verification. So that is kind of sporadic. They'd have to do it once a year, but we don't know what time during that year. So we are going to do the paper approval, and then it will be verified by the EMS consultant when they do the site visit. And if anything changes or proves not to be accurate, then it would be revoked.
Thank you both. All right, next up we have North Dakota.
All right. We can go to the next slide. So our hospital program is very much in the beginning stages of things. We just started last year kind of collecting all of our hospital PICs, and that's been a process that was helped greatly by partnering with our trauma coordinator, who made it a requirement for any trauma hospital that's a level 4 or 5 in the state. So that really inspired people to participate in the program. So we have 37 of 44 hospitals who have a PEC team. So they have an RN and then also an NP, DO, MD, who's part of the team. And that has helped us immensely. And I feel like for North Dakota, we have to have that foundation of our PECs before we can really start building into our program. So that's kind of where we're starting there. And if we want to go to the next slide. Most people are really interested in doing their best for kids. And so that's helped. I talked about kind of our state trauma. And I've been in this position for almost 3 years now, and I find that the more and more I get out of my little silo, the more I can get done. And so just establishing EMSC as an important program within the state and the things that we can help with has really done a lot to start getting people to talk about us more and want to do stuff with us. So next one, please. Barriers. We are not mandated like trauma, stroke, and cardiac for North Dakota. So for the hospitals, this will be a voluntary program. I still pick up PRN in one of the bigger hospitals in North Dakota. And I had made these beautiful blood resistant, like you could wipe it off of this poster, like 3x3, you can see it down the hallway, pediatric poster that had normal vitals, like who we call for transfers, all these wonderful things on it about pediatrics. Sent them out to the hospitals. The hospital I work at hadn't even gotten it out of the nursing director's office to put up. And of course, the excuses are always, we don't have the staff, we don't have the resources. With some of the changes in federal funding and such, we're seeing a lack of funding in some of those more rural hospitals. So that's kind of what I've been working against. I will say that getting the PECs together has really helped people be more interested, because I get emails, I think, every day from a hospital or from EMS wondering about pediatric specific things. So that's been great. They know that I'm a resource now and I have that foundation built. But I'm so glad to listen to all of you with your wonderfully established hospital programs, because that's my direction that I'm working towards. And then my next steps would be obviously making of that proposed program, sending it through my advisory committee. I've thought about sharing it kind of with the PECs who've been with me from the start, who are really involved, to get their direct feedback also into what's going to help us. We're just very beginning, so I apologize. I don't have a whole lot of info, but we're getting there. And that's all I have for hospital, I think. And then, oh boy, we can go to the next slide.
If we want to pause there and see if anyone has questions, or if you have any questions about your hospital program, and then you can share an update.
Thank you, Michael.
Yeah. All right. Well, if there are any, feel free to put them in the chat. We can get to them after your EMS program.
Okay. So our EMS program, hot mess express here right now. We had a program prior to me being hired. That was 2 or 3 program managers ago, and they had about 25, 30 hospitals who were part of it. I updated that program to more align with all of the information that was out at that time and went back through the steps of it. But after we put it out and I sent it to HRSA, we only met minimum qualifications for that program. So I pulled it off in the fall of 2024 because I want to rework some of it, obviously. Here was kind of the list of areas that we needed to improve in our program. And some of this, I think, was because it started as a 20-page document that really explained what the program was about, what you were signing when you attested to things. But that part was pulled by people who have more power than I do to simplify it and really make sure that they knew it was voluntary. So I feel like we lost some of the content. So if we go to the next slide, I'm going to work on sending that through and seeing if we can gain a little more traction as North Dakota EMSC has gotten a little bit more into the state. It will be put online again, fillable form that can be emailed to me. I keep track of all of my PECs and eventually my recognition program people through just an Excel file. So if that Excel file goes away, tragedy. We had 2 agencies who did sign up for the revamped program. And one of the things that we did to kind of promote it was we have this little ambulance. Some of you might also have Andy the ambulance from that company. I think they're based out of Utah, and all of their stuff is like from the 1980s. It's fantastic. So we have the ambulance at conferences to kind of promote, because if you're recognized, you get to use this in your community. And I have things like coloring sheets to go with it. So it's a nice perk for them. Next slide, please. Some of the things, our verification that obviously we need to prove was a lot of attestations. And now we're going to change that definitely to add a site visit or a virtual visit, just because North Dakota driving in the winter, sometimes our roads are literally snowed in and you're not going anywhere. So we'll be making sure to require that with the new program that we have set up. And then the next slide, please. So I like to push everything through my PECs. We have 219 services and I have 83 PECs right now. Definitely we're using that ambulance. And then as I was typing these slides up, I was like, oh, I wonder if I could start paying for ambulance licenses for those services that are recognized. So that's just an idea I have, and I haven't floated it through anybody or checked to see if that's something I can even do. But it was my little light bulb at that time. And we can do the next slide.
That's your last one.
Oh, that's my last one. Okay, so that's kind of where I'm at with things. I've made some mistakes, but I have room for improvement. But questions? Lots of concerns, I'm sure.
I have a question.
I appreciate you sharing today and sharing your journey and everything that you have going on and that you're working through. Appreciate that. One thing that you mentioned when you were referring to your ED program that you think has been really helpful is that you feel like you've been able to get out of your silo and reach new people. Has there been something that you have found, one thing you did to do that was really beneficial, or how do you feel like you accomplished that?
I don't mind being awkward, and that helps a lot. So if I hear about things that are happening that I think would really work well with EMSC, I just reach out. I do a lot of cold emailing to people and go, hey, here's what I kind of do. Let's work together on things. And that's living in that uncomfortable introduction has kind of been my jam.
I like that. Good advice. All right. Any other questions about the programs from North Dakota? Next up, we have New York.
Hey, are you able to hear me?
I think I'm having a hard time hearing you, Amy.
Okay, hang on one second. How about now? No,
Still pretty faint.
I'm having computer issues. How about now?
Can hear you. You're just very, very quiet.
All right, so I can speak louder. Does that help?
That's good.
All right. So yes, my computer decided to do what it wanted to do yesterday, and I couldn't take another day of not having a computer, especially because the whole day is full of meetings today. So I am borrowing a computer. It is not set up to anything that I do at all. So I hope that you can hear me. Thank you for your patience. So obviously, hey, it's Amy. I'm from New York, and I'm going to talk about, we already have a pediatric recognition program for EDs. But in our area, we are in the process of building a pre-hospital one. All right, so yeah, we're in the initial planning program. So, and I'm not sure if Megan already went, because there is a section of the Northeast we work together, and most of our programs are called Always Ready for Children. So the base of the program is similar. We work together using guidance, best practices, all of that. But then we take that base program, we take it back to our state, right? And we make it more applicable to our state, because we all know each state has their own individual needs, and they also have their own individual legislation, regulation, protocols. Some people are in right, academic institutions, some people are housed in government, and all of that makes a difference. So we're in the initial planning program or section for a pre-hospital recognition program. So we are assessing the grant requirements and needs, and I think we had started talking about this last winter, just before the new performance measures came out, or the adjusted performance measures came out. So so we stalled a little bit waiting for those, just to make sure nothing significant had changed. So assessing grant requirements and needs. And then also the regional strengths, weaknesses, opportunities, threats. So we've been talking about what everybody's able to do, where that bar should be to be like the foundation of the program, for then us to take it back to each individual state. And then I have also been assessing my state strengths, weakness, opportunities, and threats, because over the last couple years, we have had some growth here in our system and hospital system. So, right, it's a benefit and it's a weakness, because we're growing. And so a lot of our work is focused on the actual growing and becoming a division from a bureau. So essentially 40 employees to 220, right? And now having 3 bureaus. So a lot of our stuff is we're hiring, we're putting the building blocks in for the EMS system here to expand it. So while that will be a strength, it is also a weakness, because there's only so many hours in the day, as I'm regularly reminded, and that I remind myself when the day runs out and I haven't done half of anything I had planned that day. Not that any of you have ever done that. So next slide. So some of our enablers is that we already have one for emergency departments. We have 35 hospitals that have been reviewed and approved here in New York State. And that sounds really great, but let me share that I have 188 hospitals across the state. So it's still right like a smaller percentage of those hospitals, but they are passionate and excited, and they're sharing it with their friends, right? They're sharing it with other hospitals, and so actually, I have probably 10 hospitals in the queue to review that have been putting in their application. So I'm very excited for that. I'm excited to see what's coming in. So we do have that, and the emergency departments are very excited to work with EMS. And on both sides, because we currently have pre-hospital pediatric emergency care coordinators. So that's 250 of our 1,760 agencies do have a PEC within their agency. Some of them have multiple PECs, which is why we have 250 agencies, but 300 PECs. Yeah, Kelly, it is, right? It's really great. We started that program in 2019, but again, right, that's still maybe 15% of everybody. However, all the people that are involved in both programs are excited and they want to work together. So in the late winter, early spring, we are planning to have minimum 2, but maybe 3, just because how large our state is, PEC symposia. So workforce development for the pediatric emergency care coordinators in Always Ready for Children ED department, pediatric recognition program, and then also for the pre-hospital PECs. So that would allow them to get some workforce development, learn more about what's going on, current day, evidence-based in pediatric preparedness, but then also meet each other so that they can talk to each other. They can put a face to a name. They can say, oh, hey, oh, you're the person in my catchment area that I'm supposed to be talking to. That's great. It's nice to meet you. Right. And that helps facilitate that exchange of information across the two. Part of the rest of my job here is I work with stroke designation, and I also work with our trauma systems team to deal with trauma systems. So I have had some experience where EMS and ERs do have to work together, and I'm hoping to put that mindset to this as well. So we are also, an enabler is we are in the final stages of passing updated regulation for what's included on our ambulances. So, and I forget the whole title, but I believe it came out in 2021 or 2022, all the things that should be on an ambulance for pediatric equipment. I essentially gave that to the person that was developing the updates, and I think we got everything but 5 pieces of equipment put into our regulation. So we actually just had a meeting this morning about updating policy and policy guidance to assist agencies in what's in there, what needs to be done, and pediatric restraint devices were a piece of equipment that was included. So we're very excited for that because we have been working on that. Yeah, right? So exciting. Our New York State EMS for Children program is housed in our division of state EMS. So that helps with if we need regulation, if we need support from hospitals, right? Hospitals is over there, right? So I can go to my boss, and if somebody's available, we can take a walk and have a conversation, right? So that is definitely an enabler. And it was an enabler with Always Ready for Children. We didn't have to, Chetty mentioned a lot of hoops and permissions and things. With Always Ready for Children, we did not have to jump through as many hoops with hospitals division. They were like, are we doing the program or are you? And I was like, we administer the program. She said, that sounds great. Go do it. So I was like, oh, this is the easiest meeting I've ever had in my life. I had 7 months set aside for this. This is great. We have a lot of support from our advisory committee. So our EMS for Children advisory committee. And happily, we now have a PPN node. So one of our hospitals, Cohen's Children's, who the PPN PI is on our EMS for Children advisory committee, is a former paramedic, is an EMS physician, is a peds EM physician, right? So he's all the things. And he is PPN PI. So he is very excited to include us in that work and wants to make it a team. And that definitely helps with our Always Ready for Children program. But I think that it's going to tie in nicely with EMS and making sure everybody is prepared. We also have a PCAR node that we work with at University of Buffalo, which is associated with Columbia University. So we do a lot of work with them, and we just had a pre-hospital care research forum event at University of Buffalo with our partners there. And there was a lot of pediatric research abstracts that came out of that. Next slide. So some of our barriers is just the sheer size of New York State, right? It's great, but so we have 1,762 EMS agencies. That includes BLS CFR. So, right, that's non-EMT, non-paramedic, all of that. It's the first responders. We say 1,060 certified because that's BLS EMT, transporting, and above. It doesn't include like fire engines that have CFRs and all of that, but still it's over 1,000. We have 18 EMS regions across the state. 43 of our 62 counties are considered rural, and we do have several frontier regions. So our Canadian border, and then some of our border with Pennsylvania are super rural. And in some areas, we transport to Vermont, we transport to Canada, we transport to Pennsylvania, we transport to New Jersey. I think we've done Connecticut, and maybe Massachusetts. So so that is kind of a barrier, but some of that we've addressed with Always Ready for Children and the program managers from all of those states working together. And that's why we all felt it was very important for us to participate together and to know each other because we share patients. Also, the programs are not currently required by regulation. So these are voluntary programs, both, right, pre-hospital and in-hospital. So essentially, this is people volunteering to say, yes, we'll take this extra thing. Now, the real thing is that you're doing this anyway. We are trying to codify it as much as possible into regulation in other places. So it's just kind of like, you're doing this anyway. Can you please sign this attestation so that you can get, right, like the benefit of our program? And once we start explaining that, a lot of people are like, oh, we are doing this anyway. Yeah, we'll sign that paper for you. Yes, we'll send out a press release that we're always ready for children, right? For them, it is definitely a win. I would also say that another thing that's not on here that I know that we are all kind of suffering from is kind of the uncertainty with what's going on with the current federal administration. It's hard to continue to plan things and to move forward on projects when you are trying to, and I know at least for me in New York, I've been trying to do this. I've been trying to codify as much as possible for within regulation and policy and all of that for children so that the things we do now within the program, if the program disappears, it still has to happen. Right? So it legally still has to happen in our state. Next slide. So our next steps is continue to work with our regional partners, continue to work with my advisory committee, continue to work now with PPN. It's been like a month, it's great. And I just had a call with them, kind of Puerto Rico and US Virgin Islands have been looking at adding things to their whole EMS system. So that's another opportunity that I think will tie in nicely here, as well as with all our other work. Develop language and standards for the program. So obviously getting the foundational document and guidance and then making it New York State. And then also working with our policy team to integrate the pre-hospital pediatric recognition program into current division policy, which is kind of, some of that is underway because we started updating our regulation, but also trying to put it in as many places as possible. So it absolutely has to stay. And it's like, oh, well, we don't have the funding. Oh, well, you have to. So I've been trying to enforce that as much as possible in all the little nooks and crannies. And then I think that's the last slide, but if you advance it one more. All right. So really, I wanted to present the pre-hospital, right, kind of getting ready, getting underway, because we're working on it now. right? And currently for me, I know some of you have pre-hospital programs, and it would be great to hear questions, suggestions, successes, failures, whatever you have that will help us with moving forward. Hey, Kelly.
Hey, great presentation, Amy. Thanks so much for sharing. I had a question. The slide just prior to this one where you had the breakdown about like 18 EMS regions. So I was just curious, how is it set up in New York as far as kind of who dictates things? Like I understand, yes, you've got codified administrative code or regulations that EMS agencies have to meet. But when it comes down to maybe some differences between, say, ALS level responses and BLS level responses, do you have like system directors within those or regional directors that dictate some of the different policies and requirements for equipment and medications and protocols?
Ish. So in New York State, right, we have the division. And then under the division, we have 18 regions. In each of those regions, we have a program agency that we contract with that helps with the administrative output in those specific regions. They are local to those areas. Some of them are in hospitals, some of them are like just 501c3s that do a bunch of different things, advocacy groups, stuff like that. So we have, I believe, 15 of those plus FDNY because they're their own because they're so big. And we have quarterly meetings with them, but then we also have, and they're contracted through the Department of Health. So they have to meet the deliverables just like we do, or they get fired, and we find somebody else, hopefully. Uh, so they help us with pushing out initiatives and different things. Within each of those regions, so at the state level, we have a state EMS advisory committee. There is a protocol subcommittee in there. We have a statewide protocol set that all the program agencies except for New York City use because New York City is mostly FIDNY, and yeah, there's a lot of political stuff there, but they have their own, and really the protocol sets very similar. So the protocol sets are on our website, so anybody really can go click on them and see what we're doing. But again, those are foundational. Then at the region, there are regional EMS committees. Those regional stakeholders and representatives make up part of the state council, right? So there's one rep from each of the 18 regions, but then in each region, they may have more than that. They can look at specific things like stroke and say, in our region, we have 3 stroke centers. One's a primary stroke center. This one does thrombectomy. And so we're going to have a specific policy expanding on the statewide policy saying, okay, instead of 3.5 hours, we're expanding it to 24 hours. You're going to use this LVO scale. And here's what we want for pre-notification. They can do that. So there are regional sections. And then obviously the agency medical director has a good bit of say in what's going on in their agency, their formulary, things like that. And luckily, we have some very active medical directors in EMS here in our state. So there are several layers, but really, like New York State kind of puts that guidance in, and then it trickles down. Thank you.
Thank you, Kelly, for your question. Any other questions for Amy? Not seeing any in the chat. Thank you again, Amy, for sharing.
Thank you.
Great work going on. Next up, we have Maine.
Good afternoon. Get my video to work here. Sorry. We can jump to the next slide. So the update from Maine for our hospital recognition is that we currently have 9 of our hospitals. We have 34 hospitals that have 24/7 emergency departments in Maine. 9 of those are recognized through our Always Ready for Children program that you've heard of from other states, that has a similar basis as New York, DC, New England states, New Jersey. And what's interesting about ours is we have a very good champion within one particular hospital system that is at the C-suite level, and she has pushed hard to mandate her hospitals within that system become recognized. So they've gotten a lot of resources and support from their corporate structure to achieve this. And we meet very regularly and work with individual hospital needs, but it's consistent and coordinated from the corporate level. So very grateful for that help and been working with them. We have, some challenges with the other hospitals where we've reached out. And of recent, the challenges mainly center around financial challenges of staffing and funding to have time set aside to review and create a lot of the documents. We find that most of these hospitals have all the equipment, but to be able to pay for certifications like a PALS or NRP class, or to develop policies around some of these things, they just don't have the protected time to be able to do that. So that has caused them to not be able to apply or reach the standards of the Always Ready for Children. We had one hospital in Maine that originally just closed their OB facility, and within 30 days, they closed the entire hospital, which was a big challenge in our system. And right now, we're working with a lot of challenges with newborn and obstetrical services, where 50% of our hospitals don't have inpatient services for obstetrical or newborns. So we're seeing a lot of desire for focus on effective newborn transport and movement. Sorry. Sorry for the dogs in the background. Um, uh, Additionally, we've had 2 hospitals that have had major cyber attacks that have caused them to have all hands on deck, where they lost the ability to do anything radiographic, email, and one of those hospitals had over 45 days of inability to do email and things like that. So their focus has been on other aspects like that. And next slide, please. So our application is pretty straightforward. It's online. I hadn't really thought about putting it into an electronic format, and I like the suggestions from others, and I'm probably going to explore doing that. Right now, it's pretty easy because I don't want hospitals to say, "Oh, I'll get to this tomorrow. It's too long." I'd rather have them engaged, and when they're thinking about it, go, "Oh, this is pretty straightforward to apply." And then once I've got them into the system, spend that time to review documents and policies and the needed items. I have encouraged all of them to redo that survey because it was last done in 2021, and that was during COVID. And we've had so many changes in staffing and resources that we found significant changes from what they originally done and what they're able to spend some dedicated time with. So that's helped them really look at what are they at today as opposed to what were they at during COVID. Um, as I mentioned, we had 9 applicants. They've all been approved. I have 2 others that are significantly interested that I've been working with, but they haven't yet submitted an application for hospital recognition. And next slide, please. Um, if we really work with the hospitals of what's comfortable for them. We'll meet at the hospital as desired by the applicant, and we'll go in. We find that it's not counting endotracheal tubes or equipment. We've had great success with hospitals having the right equipment, especially with the lists from the survey. They can use that and go through. And we really look at equipment as a low-hanging fruit and let them charge through that. What they need most help with is policies and goals around that, is to really look at where are they today, what policies do they need to develop, but we don't want it to be static. We want this to be, okay, if you achieve recognition today, what does tomorrow bring? And what are your goals to keep improving and not stay static in that effort? So we'll work with them as they wish, but most of the time it's virtual meetings where we share documents back and forth, review it, make suggestions. And I'll talk a little bit more about that in a second. So we can skip to the next slide. So we, with some of the EMSC federal funding, we contracted with the Maine chapter of the American Academy of Pediatrics, and we have a statewide physician champion. One of the difficulties we had was I'm a paramedic, and I walk into a hospital from the Maine EMS office. We have no authority over hospitals. We don't regulate hospitals from our office. And so they kind of like, well, great, you're an ambulance driver. Why are you here? But I've used a pediatric physician through AAP that has really been our champion, and she's worked a lot as well with those hospitals and been a great additional voice with that and connect. And I think a lot of the hospitals feel a lot more comfortable hearing it from a physician. Um, so with our contract, she's been reaching out to all the hospitals and gaining interest and developing primarily PEC resources and attracting PECs. Right now, we have PECs in 29 of our 34 hospitals, and out of those 29 hospitals, we have a total of 52 PECs. So most of them have multiple individuals that are doing it, both physician and nursing, sometimes more than that. Some of our hospitals have EMS liaisons and EMS managers within the hospital. And we involve those EMS managers as well to find that connection and collaboration between a hospital, ED, and the outside EMS agencies that they serve. So that's been a good addition to the PEC cadre. We developed a website in addition to our main EMS website that's listed there, the mainpec.info. And we are producing monthly classes on topics. So AAP has been working on that and putting together classes around that. And they're short, meant to be kind of beginning of shift or during shift resources. They're quick, they're efficient, they're timely of topics. And then we save them as a library that is available for them to do if they feel like there's a challenge or something they want to go back to and review. So the hospital's EDs that really like that. In addition, we've supported the annual Maine State American Academy of Pediatric Conference, both financially and with information. We've presented, our fan has presented at that, and we've had a booth at that conference. And that has allowed a lot of connection with not just hospitals, but with primary care pediatricians across the state, and allowed for connection at all aspects of pediatric contact for healthcare. Next slide. So the recognition program for EMS. So in New England, we often have the statement when we don't want to talk about something, we say, how about them Red Sox? And I would say that our EMS recognition program is desired, but it's not even in a usable state yet. We're working with some of the collaborators with the hospital recognition program to develop some strategies. And I think, frankly, that the idea of putting together the criteria for the program is not going to be that difficult. Me going out and meeting with the 290 EMS services across Maine is going to be substantially challenging. About 30% of our EMS agencies in our state do less than one call a week, and 50% of our EMS agencies do less than one call a day. So a lot of these are small volunteer agencies that don't have a lot of time and give all they can just to keep their trucks on the road. And so going in and doing this, I really need to have a lot of support and structure around that, of not just here's what you could do, but here's how I can help you get there. And so having a lot of those policies in place, and we do have good state policies, state regulations statewide of equipment. We have good pediatric protocols because we use statewide protocols. And so we have some infrastructure, but actually getting them to follow through, and primarily with training and education, is going to be our biggest challenge around that. So that is a very slow aspect of that. No, and Amy, no photos of Yankee Stadium, and I am a Yankees fan over a Red Sox fan, so I get a lot of eat hairy eyeballs in Maine when I say that. So, but I can say that to you, and I actually happen to be in New York right now, so it's protected, I guess, in both ways. So I think that's my last slide, but I'm happy to answer questions as people might have.
you so much, Mark. What questions do you all have for Mark?
Hey, Mark, this is Mike Berg from Virginia. Where is your EMSC program housed? Is it in the office or department or Bureau of EMS?
Yeah, so it's within our Department of EMS, which is part of the Department of Public Safety.
Okay.
So we don't sit in DHHS or any of those things, but I maintain a very, very close relationship with the maternal and child healthcare directors for DHHS. I meet with them weekly, and we talk by email probably every other day. So we have a good collaboration with them, and I'm involved in a lot of DHHS committees. I'm the chair of one of the committees for DHHS, which is a little weird, but I do that. And we do a lot of integration with, particularly around perinatal health, with working with, as I mentioned, the newborn transports, but we also have a perinatal transition program that, these don't really look at, but we have a very robust midwifery program in Maine. And so we're working with the State Midwives Association for better handoffs when they have something go awry at a planned home birth or a home birth that occurs in a birthing facility or birthing center, that when they need to transfer them to the hospital in the past has been very challenging and very difficult. But we've worked on pathways of handoff reports and collaboration around that. And we actually supported and spoke on DHHS has hired a midwife to be a transition program director within that office, and that's helped as well. So,
Thanks for
back to your original
asking.
question. We're in the office of EMS
No,
and
great. I appreciate that information, and I'm glad you're able to reach out to those folks. The reason I asked, this program is housed within the Office of EMS, which within the health department, which we also license the hospitals. The health department does. And of course, trauma programs is in the Office of EMS. So when you mentioned as a paramedic going into the hospitals and getting the looks and say, you don't have any authority over us, at least I think I could reach out and use that as a stick, if you will,
Yeah.
if I needed to from my side. But thanks for the answer. I appreciate it.
Yeah, I think the main goal is to find a champion within the hospitals, and if you can find a champion within a health system, that is the best way to do it. Your pediatric hospitals are usually great for that, but usually there's a C-suite women in services line that could be very helpful for that. I would encourage you to find that person.
Thank you so much, Mark and Michael, for your question. Next up, we have Illinois.
Hi, Casey. Hello, everybody. Thanks for letting me share with you this afternoon. Next slide, please. So we wanted to share about our pre-hospital pediatric readiness. I know we've shared in the past about our hospital program, but we don't formally have a pre-hospital pediatric readiness program. However, we have had planning, which includes pre-hospital pediatric readiness since the late 1990s, which includes pediatric considerations having been adopted into our EMS administrative code within all the EMS and pre-hospital provider program. And then we also have a pediatric pre-hospital committee, which, if you can tell by the middle picture here, with our EMS, our Emergency Medical Services for Children kind of format here, under the Department of Public Health, we have our EMSC Advisory Board, and the Pediatric Pre-Hospital Committee is one of our 4 subcommittees that report up to that board. And this pre-hospital committee, it really is quite engaged. We have a lot of stakeholders from within our EMS regions. I know the map is kind of small, but within the state of Illinois, we have 11 EMS regions. So we have representation from each of those, as well as other pre-hospital organizations. We utilize this committee to help identify different pediatric considerations or recommendations for improving our EMS administrative code or other best practices. And then over the years, again, even though it's not a formal pediatric recognition program, we have had discussion both with this committee as well as internally at IDPH on pediatric readiness processes and a recognition program development. Next slide. One of the other things as part of the planning that we have had ongoing since 1997 was just a very robust availability of education, protocols, skills evaluation checklists, and several resources that our pre-hospital providers can access. I tried to put a smattering of screenshots here to give an idea of what we have on the far left of this screen. It looks kind of like a little list. There's some red text. I know it's really small, but it is a free online learning management system that we partner with that houses all of our education. And it does give state site code continuing education. And it's good for physicians, advanced practice providers, nurses, and pre-hospital providers. So we really try to help make it possible for healthcare providers to meet educational requirements. Next is our Pediatric Pre-Hospital Emergency Care Coordinator flyer. This was developed a couple years ago, and we've been sharing that out, especially when we go in person to conferences and symposiums where we have a chance to meet healthcare providers. We're able to talk and engage that the PEC role with our pre-hospital providers. And then on the other side, I'm not going to go through each and every one of them. It's just some examples of some of the other resources we have. But one of the things that we did create a few years back, and this was created through utilization of some of the HRSA EMSC funding that we get, is a document. It states with pediatric pre-hospital recognition programs, an overview report. And at the time this was created, I believe it was 2023 when it was finished, the hospital or the state programs that were willing to share information about it, they were all captured here within this document so that we had a resource we could use to help develop our program moving forward. And we are willing and have shared this out to anybody that is interested. Next slide, please. So growing and moving on, we really wanted to kind of share about where we are now in our development phase. Even though we've been planning for years, we're actually really starting to bite into the whole development. So we're about 5 to 6 months into this process, and we have determined at this time that we do want it to be a voluntary program. However, with the committee, we are still working on trying to identify how many levels or tiers. We are considering a 3-tiered program and utilizing as our naming convention some terminology that we've already seen out and about, such as PEDS Ready at a bronze, silver, or gold. However, these are not finalized or confirmed. As far as trying to identify what our criteria would be at each of these levels, we really are leveraging the recommended minimum criteria that came out of the work here with the collaborative prior to the exchange, as well as utilizing the performance measures and all of these components that are already incorporated into our EMS administrative code. Additionally, within our development phase here, we are working on drafting an application, and we're pretty fortunate that we have some good examples that our EMS agencies are used to utilizing for their EMS licensing, as well as our hospital recognition program. And so we're trying to utilize those to develop our application. And what we're envisioning is that just like the current structure is that these would be fillable PDFs with some different drop-down options within them that they can submit electronically as well as have paper copies of. Next slide, please. We do feel that overall, some of the positives and the things that help us on this journey is that we do have support from both the state as well as our Division of EMS and Highway Safety. We feel that our stakeholders are very engaged or have a lot of buy-in to pediatric readiness, and our committee members for the pre-hospital committee and upwards to our board are very, very engaged. being able to initiate and put into practice an actual pre-hospital recognition program. Something that's going to help us out is the fact that we already have existing administrative code that incorporates the minimum criteria, federal performance measures, as well as some other national recommendations. Some of the recent additions into our administrative code includes having that PEC role and having hands-on skills checks. And then additionally, in order to help the pre-hospital providers, is just ensuring that they are aware of and have access and are utilizing the modules and resources that are developed out there so that they can meet the requirements. Next slide, please. Now, on the other hand, while we have a lot of enablers, just like everyone else, we do find that there are some barriers and challenges out there. And one of the things I think that we're kind of struggling with right now is even though we have stakeholder buy-in and committee engagement, we're struggling right now with people's attendance on our committee meetings. So we're unable to have a quorum in order to vote on the different items that are discussed and, hoping to be incorporated into our pre-hospital program. Another challenge is there is some over eagerness by our committee. When we first started to sit down and look at the different components that could be incorporated as requirements, by the end of that meeting, they wanted to say they were in agreement that everything that's minimum criteria, all the stretch criteria, all the performance measures, and everything that's in like the technical report and technical documents are like, oh yeah, that all makes sense. We need to have it all. Which it's great that they're invested and there is so much buy-in that pediatrics are important. But the goal is to have those different levels and not put it all in the first tier. So just trying to work through that. One of the other challenges is our organization and oversight within our EMS system, which is one of the reasons, which really is that reason I asked Amy the question about how it's set up in New York, is we have a decentralized process. While we do have state oversight with our EMS administrative code, there are different components that are really controlled and determined by our EMS system or medical directors. And that really circles around like what sort of equipment and medications the different for ALS agencies they're required to have, what standard operating procedures they're putting in place, and even a lot of policies that the agencies follow are system policies. So they might not always have like their own agency specific policy. So trying to figure out and see how do you incorporate needing a specific policy as a requirement when the agency doesn't own the policy. As well as we have a very large volume where there's your transporting agencies versus non-transporting agencies, but they all respond to 911. And then navigating the capabilities between your municipal, your private, as well as your volunteer agencies. Additionally, we feel that there can be a challenge for EMS agencies having the capacity to meet the requirements. And as everybody has stated so far, we know that funding and staff really make that something we have to consider. And then, trying to identify how are we going to conduct the program as far as having personnel to review applications and site surveys. Really, who's going to be the owner of that? Who's going to be the one actually doing it and fitting that into all of our processes. Last slide. So for us, as we're looking ahead, our next steps would just be, continuing working with our committee and having the internal discussions with IDPH leadership, Division of EMS and Highway Safety. Is just continuing working on the outline and what the program's going to look like, developing our applications, as well as ensuring that we have guideline documents to support what it is we're expecting them to do, and really provide that guidance to interested agencies. Once we've got all that wrapped up, we do need to submit for our approval from our HRSA project officer. And we'd like to identify at least 6 EMS agencies to pilot the program. And out of that 6, we really would prefer that we have kind of that range from your urban to your suburban or rurals, your volunteer, your municipals, non-transport and transport. Try to be able to capture each of those so we can get the best feedback on, are we hitting everything the way we're expecting it or we're envisioning it to be, or what adjustments do we need to make? And then we want to make sure that we're adding program details, access to our documents for the application, for guidance, links to administrative code, list of recognized agencies, all of this into our IDPH website on our EMSC webpage, which is one of the things we do have in place currently for our hospital recognition program. And then lastly, as has been mentioned previously today, is just making sure that these processes get written into our EMS administrative code. So regardless of future, what happens with the EMSC program, that, these components are already built into our structure, and, pre-hospital pediatric readiness is going to be part of that. And I did add a little note that didn't make it onto the slides. Knowing that we all just got our PPRP reports from 2024 too, just for some of our additional steps is also just making sure we're with our committee analyzing our results to identify those strengths, weaknesses, and opportunities as a state. And, how can we utilize that to identify potential needs or opportunities within the recognition program? That's all I have for you. Thank you.
Thank you so much, Kelly, for sharing today. I am going to ask that if there are any questions for Kelly, we go ahead and put them in the chat so we can go ahead and give Florida time to share as well. So if you have questions for Kelly, go ahead and put those in the chat for me. I'm going to go ahead and hand it over to the team from Florida.
Thanks, Casey. Did you want me to share my screen or
Yeah, you can.
you want these slides? Okay. Are you all seeing just this one slide?
Yes, we are.
Okay, awesome. So thank you guys. My name's Caitlin. I'm with Florida EMSC. I'll be presenting the first few slides and then I'll hand it over to Dr. Hendry to get into the bulk of it. And we are focusing this state update on our pre-hospital recognition program as we just wrapped up our pilot phase. This is just the outline of what we'll be talking about today. So we're really focused on going over the application and verification processes, and then we'll discuss our recognition materials, marketing strategies we've used, and our next steps. This is just an overview of our program. So there's 2 tiers to our pre-hospital recognition program, Florida Ped Ready Silver and Florida Ped Ready Gold. We'll go over the criteria in a upcoming slide. And this is just an informational handout about our program that you can download. It has the criteria as well as answers to frequently asked questions. We developed a program webpage for our pre-hospital recognition program that's housed on the Florida EMSC website. It has different sections about the program, how to apply, as well as best practices. This was actually a new section we recently created after wrapping up the pilot phase. We were given permission by the EMS agencies that participated in the pilot phase to share their best practice documents to help future agencies that are interested in applying, which has been a great benefit, as well as some resources to help agencies with the process. This is our program criteria. I'm not going to spend too much time on it because we did discuss this in a previous update, but just as a reminder, this is our criteria. And as you can see, the gold tier has much more categories such as education and competencies, interactions with systems of care, and family-centered care. This is our pathway to recognition for agencies. The first step is to schedule a pre-application consultation with our team. It's not required, but a lot of agencies have requested giving us a call just to kind of answer their questions and provide guidance so that way the application process is seamless for them. Once the application is submitted, the application is reviewed by our review team. We have a review team meeting. over Zoom, and that includes myself, Dr. Hendry, as well as a few others from our advisory committee. After that, we have a meeting with our applicants to give feedback if we need any additional information from them, so that way they meet the criteria. And then we give them time to resubmit any information or provide new information and work on meeting the criteria. It gets reviewed once more by Dr. Hendry and myself, and then we go ahead and schedule the verification visit if they meet all criteria. This is our application guide. This was developed to assist applicants with completing the application. It includes everything they'll need all in one place. So there's supporting documentation checklist. This includes all the files we'll ask them to upload on the application. It includes helpful resources, as well as an overview of the application process, the verification process, renewal, etc. An applicants are really encouraged to review this prior to beginning the application. That way they're really set up for success. This is an overview of our application process. So we actually use Qualtrics to host our application. Applicants will have the opportunity to submit all their information and supporting documentation within that online application. We get a notification when it's submitted, and then we're able to review it and download it from our end. And these documents undergo a confidential review, like I mentioned earlier, by a core review team via a virtual Zoom meeting. So this includes Dr. Hendry, myself, and a few others from our advisory committee. And these individuals have been consistent throughout the pilot phase. So it's been great. They've been volunteering their time to help us out. And then we meet with the applicant to discuss feedback, like I said, and they have the opportunity to address any of those deficiencies. Now to the verification process. So once the EMS agency meets the program requirements, a virtual or on-site verification visit is scheduled. The Florida EMSC program manager, project and medical director, and members of the review team are really encouraged to attend. We try to have at least one other member there besides Dr. Hendry and myself. And on the EMS agency side, you can see who we request to be at the visit on their end, such as the chief, their PECs, active EMS field personnel are really asked to attend, and you'll see why in a few. And on the right here, you can actually see, this is a picture from one of the verification visits. You can see Dr. Hendry and myself on the right with Kissimmee and St. Cloud. They actually had a joint verification visit because they have the same protocols, medical director, etc. So it was a really great experience. This is a verification visit guide that we provide to EMS agency representatives. That way they're prepared on kind of what to expect during the visit. We'll ask case scenarios, and we want their EMS field personnel there, etc. And we have an internal guide that we provide to those representing Florida EMSC. And this just has a little more detail that we might not want the EMS agency to know beforehand. We do request photos of the pediatric equipment in advance. That way we can review them and ask any questions during the visit if we have any. And once that agency gets verified at the end of their visit, a recognition package is provided, and this includes a host of items. They get PEC lapel pins, challenge coins, a resource bag, recognition certificates, vehicle decals, etc. So it's really great to celebrate at the end of that visit. And if it's held virtually, we do mail it in advance. That way we can go over it with them virtually. And now I'll pass it on to Dr. Hendry to go a little bit more in detail. Thank you.
Okay, thanks everyone. I know we're running out of time, so I'll try to be quick. This is just an overview of what we do for the verification visit. Most of the time they are virtual. We will have some people there in person, so it's more of a hybrid situation. The EMS agency is there in person. Just Florida is so large, it's difficult to drive everywhere. You can see what we go over. We also ask the agency for a little background about their agency, some unique features that they have, how many personnel they have, do they have mobile integrative health, critical care, and we may be adding some of that to the application in the future. One of the things I put in place is my favorite part is we ask to have at least 2 boots on the ground medics there. It can be a paramedic and an EMT, and I give them a few case scenarios. I tell them it's not going to change the outcome of their verification visit, but I want to make sure it's not all just paperwork, that they actually know, what their protocols are and how they would respond to certain pediatric situations. So that is a lot of fun, and everyone seems to enjoy that. We also do a SWOT analysis with the agency at the end about, what are opportunities and challenges for them regarding pediatrics and neonatal cases. And then we ask them for feedback about the process of this recognition program, and then conclude with their presentations. Next slide. And then, we try not to waste anyone's time unless we feel pretty certain they're going to be recognized. So most of the work is done ahead of time. And as Caitlin mentioned, she has everything. They're mailed a package to open during the visit, which includes all the wonderful things like their vehicle decals, media package. We give them multiple certificates. This is Sarasota County with theirs. You can go to the next slide, Caitlin. And then this is what the certificates look like. This is Northport Fire Rescue, which was our first agency with their chief. Next slide. These are the decals. Believe it or not, this was one of the hardest parts of the program, trying to find the best material to make the decals. And we give them, so far, we've been able to give them however many they want. And we've done some really large agencies. If they want something larger than we provide, we give them the files and they can order those. Next slide. And again, as Caitlin mentioned, we give them a media package. We work with their public information officers so they can do announcements in their community. There have been some great news articles to the agencies we've recognized so far, and most of them are doing social media posts. Next slide. And these are just some examples of the different social media posts. You can go ahead and go to the next slide. One of the social media posts from Northport Fire Rescue actually led to EMS World News doing a story that they released on EMSC Day about Northport's journey and pediatric readiness. It was very exciting. We had no idea they were doing the story. Northport thought we had asked EMS World to do the story, and we thought, Northport just assumed we knew, which we did not, but that was exciting and got a lot of attention in the state. Next slide. These are some of the different marketing strategies. We have a distribution list. We have a quarterly e-newsletter. We put out flyers and information at our advisory committee meetings, which are done in conjunction with our state EMS advisory councils. And then, of course, your social media and other state conferences. Next slide. We did also have an ASIMSO abstract. We were still, even though we're at University of Florida in Jacksonville, we work very closely with our Florida Bureau of Emergency Medical Oversight. And here's one of the directors that was at the meeting with our poster. Next slide. These are our recognized agencies. So far, we have 7 that are recognized. So far, all in the gold category. We do have one more that we are formally recognizing in September. It's just taking them a while to get the date with everyone. And then we have one rural county recognized and one other rural county that we're working with them to meet the criteria on. Next slide. The green are the rural counties in Florida. These are just some, you can go ahead and go next. These are just some quotes. This is from a fantastic EMS medical director who has the best pediatric protocols I've ever seen. So we thought they were already very pediatric ready. And she sent us this email just about what a positive experience it had been for them and a growing experience. And then the next slide is a quote from one of our longstanding PECs. He's on our advisory committee. This was for Sarasota County, and they're quality information officers who completed their application. So it really varies who completes the application. But he said, it shouldn't be a walk in the park to have merit. It was doable. We had a few challenges, but it really improved the care that we do every day. Next slide. Just our next steps. We feel like we're at a steady state. We have reviewed 9 applications, and so we have closed the portal for now. And Caitlin is working on revising the application to try to make it simpler and to give them better application prompts with examples of what they should upload in the application. You can go to the next slide. And this is our contact information. One of the things we're going to do, this is a lot of work. 9 applications may not seem like a lot, but each application is multiple meetings. So probably what we're going to do is limit it to maybe 4 or 5 agencies per quarter in the future. And, there's already some competition with some agencies that, really want to get recognized. So that way they'll know if they want to do it, they need to, get it in gear and finish their application. I want to thank Caitlin for being on today because she's been in the process of moving all day. So I know we're almost at the end of the time, but we'll be happy to answer any questions.
Thank you both for sharing about the program today. A lot of exciting work happening, so happy to hear about it. I know we are over time, but if anyone has questions for either Florida or Illinois, they're still around for a minute. While you're thinking of your questions, I do want to share that based on the feedback we received from you all about future topics, we have a session on September 18th looking at finances of a recognition program, and then in October we'll look at assessing the effectiveness of recognition programs. But that these topics could be combined for both ED and pre-hospital. So if you're interested in joining either of those sessions, please register. And then we'll come back in November and hear from more of you and get some additional updates on your recognition programs. That is all I had for you today. And then appreciate you sticking around. And if you have any questions, please let me know. All right. Thank you all. Have a great rest of your day.